To invite our chairpersons, please welcome, in the order of appearance, Dr. Prabhatranjan Sinha, past President CSI UP Chapter and Chief Cardiologist BPS Heart Clinic, Varanasi; Professor P.K. Goyal, past President CSI UP Chapter, Director Interventional Cardiology at Medanta Hospital, Lucknow; members of the expert panel, Dr. R.P. Ellens, Senior Consultant Nephrologist from Lucknow; Dr. Louis Fisher, Chief Consultant Cardiologist at Malangara Orthodox Syrian Christian Medical College, Kolanjeri from Kerala; Dr. Ankit Sahu, Assistant Professor of Cardiology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow; and Dr. Abhishek Singh, Assistant Professor of Cardiology at Lari Cardiology Center at King George's Medical University, Lucknow. Ladies and gentlemen, our first presentation is Balancing the Tightrope Therapy Initiation and Continuation in Heart Failure and Chronic Kidney Disease. I'd like to invite Professor Vidyut He is the Senior Consultant Interventional Cardiologist at Choitram Hospital and Research Center from Indore, Madhya Pradesh. Professor Jain will have 12 minutes and then we'll take up 3 minutes for discussion. It's over to Professor Jain. Thank you very much.
Good afternoon. Good afternoon, everyone. At the outset, I am thankful to the UPCSI organizer, and I think this is one of the good conference which is holding on, and I am lucky to be part of it. I'll be sharing some of the facts about the heart failure with reduced ejection fraction with CKD. Some of my slides may raise some controversies, which I will welcome, because then there comes the solution after the discussion. So let us see what are these. Balancing the tightrope, therapy initiation and continuation in heart failure with reduced ejection fraction in CKD patient in place of RAS inhibitor. We know burden of heart failure is definitely very high. More than 21 million adults worldwide are living with heart failure, and we are facing more than 50% mortality in the next 5 years. So what is the goal of therapy in heart failure? Definitely, we would like to have increased survival, reduce hospital admission, and make the people feel better. This is what is expected by from a doctor by the patient. Particularly the patient with CKD and heart failure, we may not have many evidences how the guidelines are telling us. So we have to definitely plan our patient. The reasons being, possibly we are always worried about the adverse event. We are always have a compelling comorbidity and limited understanding of the proteinuria. So the burden of heart failure is more when the patient has CKD or he develops CKD later on. It becomes difficult to optimize medical treatment, often associated with the abnormal rise of potassium, which is dangerous, and creatinine. So cardiorenal syndrome, you all know. Ultimately, once patient develops cardiorenal syndrome, his prognosis is little poor in the form of that he gets recurrent hospitalization. And then ultimately with recurrent hospitalization, we have seen the patient worsening, and there's a premature death or sometimes sudden death. So there's a bidirectional interaction between heart and kidney. You all know about it, because both the organs are very important, whether it is heart or kidney, because there's increased RAS activation, oxidative stress, inflammation, increase in sympathetic nervous stimulation, and neurohormonal mechanism. They both damages kidney as well as the heart functioning. So what is pathology of heart failure in CKD? We know in CKD there is a chronic pressure overload because of hypertension. Many of these patients will have volume overload, and this patient may have cardiomyopathy, which may be ischemic, non-ischemic, or uremic. And they may have additional risk factors. Many patients have diabetes, obesity, poor fitness, anemia, may have coronary artery disease, myocardial infarction, or infarction. Ultimately, all that lead to reduced ejection fraction, further deterioration and progression of CKD and heart failure hospitalization, sudden arrhythmia and death. So heart failure and kidney disease often coexist. You know all it. 20 to 40% of heart failure patients will have rise of creatinine by 0.3 or more. And 44% of end-stage renal disease may have heart failure. So both are going together. And survival in heart failure and CKD patient decreases over time. We have seen our patients who are at 1 year and 2 years, sooner they develop renal failure, their survival becomes poorer. Or renal function dysfunction once occurs is an unwanted barrier with heart failure therapy. We know RAS inhibitors have shown incremental benefit in the improving quality of life, reduced hospitalization, and over mortality rate. However, worsening of renal failure is also common during heart failure therapy, and it has been associated with decreased survival, increased hospitalization, disease progression. The cause of worsening renal failure during decompensated episode needs careful thought regarding the volume status of patient and whether the RAS inhibitor are of prognostic benefit or not. So these are something which you already know, that is ESC guideline for heart failure with reduced ejection fraction. This slide is known to everyone. It doesn't have any controversy. We always use ACE inhibitor, RNA, beta blocker, MRA, SGLT2 inhibitor and loop diuretic for fluid retention. Problem comes when patients will develop the kidney problem. So evaluation of pharmacological treatment, you all know, we had a RAS inhibitor in the form of ACE inhibitor, ARBs and MRA. Now we got the other advantage with in the form of the RNA, which is a combination, you all know, sacubitril and valsartan. So there are two types of the properties. Sacubitril definitely gives decrease in blood pressure, decrease in sympathetic tone, decrease in aldosterone level, decrease fibrosis and hypertrophy, and increase net uresis. And RAS activation, definitely RAS inhibitor has all those properties are in this particular molecule. So we'll try to see how it can help our patient. So what are the treatment options in heart failure and CKD? Well, from the cardiac point of view, MRA, SGLT2 inhibitor, beta blocker, ACE inhibitor, ARB and RNA, evaporated and CRT. From the decongestion point of view, we have diuretic. From kidney point of view, they have their management in the form of hemodialysis. Now regarding this particular treatment, what drug you will start first once the patient has got heart failure and CKD? So there are certain things which are very clear and certain things you decide by your merit of the patient what he requires. So pharmacological treatment choices, we definitely have ACE inhibitor, ARB, beta blocker, MRA, and they are all very powerful background as the various studies have been done. The newer studies like paradigm study or DAPA-HF has given the foot for the neprilysin inhibition and SGLT2 inhibitor. Vericiguat will be a newer addition, although we don't have a lot of study, but Victoria study has taught us something, evaporating for limited patient. Heart Failure Association of European Society of Cardiology has made a statement, patient with CKD with rise of the potassium, you can start with beta blocker, diuretic for the volume reduction and SGLT2 inhibitor. AC inhibitor, ARV, RNA, MRA, they will be based on the what is eGFR, what is potassium value and what is creatinine. The drugs like hydrolyzine isosorbate dinitrate or potassium binder and vericiguat will also depend upon the availability because hydrolyzine and isosorbate nitrate causes tachycardia and fluid retention. So one should be careful if he is replacing AC inhibitor with hydrolyzine isosorbate dinitrate. So well, what are the main drugs? Again, same MRA, ACE inhibitor, beta blocker and other drugs as I already told you. Beta blockers, easy, bisoprolol and corbisolol. You have a proof with Capricorn and Copernicus trial and CBIS trial for bisoprolol. And you can start with a dose of 1.5 to 5 milligram and corbisolol you can go up to 40 milligram because many of these patients are hypertensive and they will tolerate beta blocker and they will get benefit. Mineral receptor antagonist, there are some problem. You can start in all patients with ejection fraction 35, but you must check potassium at baseline, should be less than 5 and creatine should be less than 2.5. Modify the doses if you started. If potassium is going beyond 5.5, then reduce to 50%, but if it is above 6, then stop MRA. If creatine is about 2.5, again reduce the dose by 50% and more than 3.5, you have to stop the MRA. Now comes some controversial things. AC inhibitor and ARB. There is an increasing association of exacerbation of renal failure with ACE inhibitor and ARB more so in elderly hypertensive patient more than 65 years of age. This is our clinical problem. These are the patients which we treat. And we often see we started AC inhibitor and there possibly GFR is coming down and their creatinine is going higher. So the biological plausibility of AC inhibitor and ARB to protect kidney against the background of multiple pathogenic pathway to account for CKD progression appears to be not very defensible. Means AC inhibitor ARBs are good drug, they do good, but sometimes a selected patient may worsen also, and this is our clinical practice also. So acute reversible decline in GFR at initiation of therapy is seen in 10 to 20% patient with ACE inhibitor and ARB. GFR reduction is due to lower systemic blood pressure and vasodilatation of efferent arteriole, and thus intragranular pressure reduces and GFR comes down. Increase in creatine level has been seen to 10 to 20% in 14% of patients, and it may increase up to 30% and affect 1.7%. Incidence of hyperkalemia is of course above 5.5 has been associated with the RAS inhibitor. So what do we do? Initially, we'll stop MRA in such patient, and then we'll still continue AC inhibitor and ARB. There have been very, very few studies which are assessing the benefit of AC inhibitor and ARB in cardiovascular risk reduction with advanced non-dialysis CKD. Because what is the problem? There are not many studies being done because most of the patients are excluded because of the risk factor. So there are only 2-3 things which I could read. Both the statements are opposite to each other. One study which was Clark, he had done around meta-analysis of the 5 randomized trial. He found there is a decrease in GFR by 20 to 30% and increase in creatine level by 0.3 from baseline at the 2 weeks. However, there was one study which was done for Stop AC trial. It was found in 1233 patients in 5-year follow-up. AC inhibitor ARB discontinuation was associated with the increased risk of both mortality. Hence, you would like to continue sub-RAS inhibition. So don't stop only on the reduction of GFR. But let us see what more can be done. So it was found out that 19% increase in the risk of mortality with worsening of renal failure on heart failure patients who are on RAS inhibitor. Well, this is our common practice. So what do? We usually try to stop the drug. That is RAS inhibitor we are stopping because patient is worsened. But what ultimately will happen? Patient will worsen because we know advantage of RAS inhibitor has been denied to this patient and we wish to continue. So what can we think about? So RAS blockers still are life-saving treatment in patients with heart failure reduced ejection fraction regardless of worsening renal failure. Up titration to maximum tolerated dose should be a still constant goal. However, effect of RAS blocker on renal function is commonly misunderstood. RAS blockers are not nephrotoxic drug. They are only functional effect on renal function and should be manageable. So beta blocker and RAS inhibitor are very well validated in heart failure, but 75% of dialysis patients with heart failure were not on recommended beta blocker or ACE inhibitor. The concern was again hyperkalemia. The newer heart failure regime may play a key role in improving outcome in CKD patient. So now can we consider some alternative? Alternative for ACE inhibitor ARB in heart failure with reduced ejection in patient with CKD. As a RAS inhibitor, managing eGFR, preventing further rise of creatinine and potassium in heart failure to reduce rejection to CKD. So there are certain activity. We know neprilysin activity and vasodilation, nitrogen diuresis. This definitely benefits patient in addition to RAS inhibition. That is good part of it. Okay, we have got both the things in our hand. So what is the impact of it? Impact of it is there is a superior impact on the other than, because it was compared with the other RAS inhibitor, it was found that there is a 30% lower risk of renal dysfunction with sacubitril valsartan as compared to other RAS inhibitor, which we have been using for at least 2 decades. So for 2 decades we learned that RAS inhibitors are good, whether it was a ARB or whether it was a AC inhibitor. But we were always worried about the renal, and we didn't have anything to compare. Now we have something to compare. ARNI led to a slow rate of eGFR decline versus nilafil. It was seen in the paradigm trial. Discontinuation of the treatment due to renal dysfunction ACE inhibitor can be 20% reduction, 30% reduction of the end-stage renal disease. So if a patient who is already on ACE inhibitor renal failure, what would you do once the patient is developing worsening? We can start either ARNI in such patient because creatine is still in the limit. Now, ESC guideline and ACC has already told initiate RAS inhibitor like ARNI in first line therapy for all heart failure patients. Now we don't require to do dosing adjustment when GFR is between 30 to 60, but below that you have to adjust. And it has been found there is a definite improvement of the renal safety, 11% reduction of the incidence of worsening of renal failure, significant improvement in LVEF and sacubitril group, and 14% reduction in cardiovascular death. So in conclusion, heart failure is reduced ejection fraction of CKD often poses challenge in medical management. Drugs like beta blocker, SGLT2 inhibitor, diuretics can be given if no contraindication. MRA should be used carefully. Team approach with nephrologist is rewarding. Such patients are in polypharmacy needs watch to be drug interaction. In real world setting, RAS blockers should not be stopped for the fear of hyperkalemia. However, if you feel your RAS inhibitor you can change, then you can possibly think about ARNI, which is novel, and of course you have now experience of 4 or 5 years, you have been using ARNI also. ARNI shows improvement in eGFR, significant reduction in the risk of cardiovascular death or heart failure hospitalization for patients with reduce ejection fraction in CKD. That is what is a real world setting. So of course, management of the heart failure with reduced ejection fraction CKD often poses a clinical challenge, and we are not able to do optimal management. However, with teamwork and possible properly timing monitoring of the biochemical parameter, you can play with the drugs and possible patient outcome will be better. Thank you very much.
Thank you very much, Dr. Jain. It was nice presentation. What about the comorbid conditions such as any
Digoxin.
Yeah.
Well, I will not use until atrial fibrillation. It's very, very narrow window. The guidelines say if there's atrial fibrillation and if you are very sure to use it, but I think it creates more problem when patient has renal failure of creating 2.5 or then it becomes really a bit risky for me.
Any questions from experts? Comments?
Yeah, Professor Jain has presented the right data. Overall, what I feel, I am a practicing nephrologist and I come across, can I continue?
Yes, yes. I welcome.
So, we come across lot of cases who have CHF, dilated cardiomyopathy or post-MI reduced ejection fraction. So they have heart failure with reduced ejection fraction and renal failure. The guideline-based therapy should continue as has been suggested. The beta blocker has strongest evidence, followed by RAS inhibition, the ACE inhibitors, ARB, followed by this mineralocorticoid receptor antagonist. So continue to give. Yes, we remain more conscious that hyperkalemia is not occurring. For renal failure, it is said that renal failure is known to occur. GFR transiently declines after use of ACE inhibitor, after use of SGLT2 inhibitors, and even with diuretics. So, but eventually we have to adequately decongest the patient. We should not leave the patient fluid overloaded, symptomatic, fearing that he has developed AKI or CKD. So the same guideline-based therapy has to be continued. One should not interfere in the management being done by the cardiologist. It should be continued. The diuretic should be given. And there is a term that there is a permissive AKI, meaning thereby there would be a transient fall in renal failure which over 4 to 6 weeks probably would stabilize. So okay. This is, sir.
One minute please. Yes, sir. Your comment?
What I feel it is a paradoxical thing with the nephrologist and cardiologist. If they decongest, cardiologists, if they decongest, they go into, likely to go into renal failure. And if they overhydrate, our all nephrologists, they overhydrate. They go into congestive cardiac failure. In between these two situations, a wise nephrologist and cardiologist will interact with each other and we go for the short dialysis in that situation.
Dr. Bansal, you are very right. I fully agree. But eventually what I wanted to transmit to the message to the audience is that permit the cardiologist to fully decongest. Otherwise patient would remain symptomatic. A nephrologist would only see from perfusion point of view. A cardiologist is taught how to look at the cardiac output, how to look at the fluid overload state. So both should interact.
Sorry for the interruption.
Short of time, it's a team.
We'll have to
Short
carry
of
on
time,
with
it's a team
next
approach.
Yeah.
And they are to be balanced, and in between they are to be dealt with the micro-dialysis.
Okay,
So the
Mr. Chairman,
consensus is it should be a team approach, no fluid overload, decongestion should be there,
sir.
optimization of dialysis by the nephrologist, guideline directed medical therapy and recirculation therapy by the cardiologist.
Yeah.
Thank you very
Thank you
much.
very much.
Nice presentation.
Thank you, Professor Jain. We'll move on to the